consultant cardiologist and cardiac electrophysiologist. I'm honored today to be joined by my colleague, Dr. Amrish, who's a consultant cardiologist in Fujairah Hospital. Inshallah, will be also joining us Dr. Amal Al-Haj, who's a consultant cardiologist and cardiac electrophysiologist working in Mediclinic in Dubai. So my friend, Dr. Amrish, is going to start, and he's going to give us his talk about the atrial fibrillation, answering the question or addressing the question, are all NOACs the same when it comes to atrial fibrillation management?
Thank you very much, Dr. Omar. This is, I was supposed to go second on that talk, and but this talk is appropriate because we have a patient with atrial fibrillation, we know we have to start NOAC, but the question comes always in our mind, which NOAC to change. So today I will try to go what I understand the NOAC from our point of view. The reason we are having this meeting and we are discussing is that all of us in this room, including Dr. Omar, myself, and the attendees, they know very, very clearly that atrial fibrillation is one arrhythmia which a clinician faces most commonly in the clinical practice. And it is seen very clearly that as the time will go, majority of the population may develop atrial fibrillation. And so the incidence and the prevalence of atrial fibrillation is nearly 1 in 3 in middle-aged population. It is a deadly arrhythmias, a part of the symptom burden because of the risk of thromboembolic phenomena, mainly related to the strokes. So overall, atrial fibrillation, the risk of stroke is 5 times that of a general population. And such a stroke is more likely to be big stroke and a dense stroke, and therefore causing more fatality. So on stroke associated with atrial fibrillation is nearly 2 times more likely to be fatal than that associated with the without atrial fibrillation. And that is one of the reasons over the years, hundreds of meetings and the lectures have been done about how to prevent stroke in atrial fibrillation. Not only atrial fibrillation has become more common, as our population aging, we can see in this graph, as our population aging over this time, so we are the age of 2020, the population is aging, more number of people are going to have atrial fibrillation. This is because the population is aging. A background risk factors for atrial fibrillation, which is age, hypertension, are becoming more prevalent in the elderly population. So the atrial fibrillation as arrhythmia incidence will increase all the time. And this is actually a big burden or a big piece of work for the electrophysiologists in this room. 2 of them are there. And they keep on dealing with atrial fibrillation day in and day out, like we general cardiologists deal with acute coronary syndrome. And that is the reason, if you take the European Society guidelines of 2020, they say in the better care approach, and the atrial better care approach is ABC approach of atrial fibrillation. So because we want to go with the basics and go to the school. So the ABC, it talks about A is the point of anticoagulation to avoid stroke. And they base their thing is that we have to actually identify not the patients which receive anticoagulation. We have to identify patients which are at very low risk who do not receive anticoagulation. That means the default strategy is for giving anticoagulation with the patient. So how do we select patients which don't require anticoagulation? Obviously, we cannot just look at the patient and say that you are fit to be anticoagulation, you are not fit to be anticoagulated or fit to be anticoagulated. We have to have some risk scoring system. So over the years, hundreds of risk factors have been identified. And this is a table taken from the European Society 2020 guidelines. And you can see on the left-hand side, the clinical risk factors, and on the center, on the right-hand side, are other clinical risk factors, imaging biomarkers, and the blood and urine biomarkers. But universally, general people have accepted, the guidelines accepted, that we can simplify all these 50, 70 risk factors into a simplified form. And this form we call something which is called as a CHADS scoring system. So this modified system is called as a CHADS VAS scoring system, in which there are a number of variables, and these variables are given 1 point and 2 points. So among them, you can see there are 2 variables which are given 2 points. One is age more than 75 years of age, and one is the previous background of stroke, TI, or systemic embolism. So these risk factors carry a more higher weight, and the maximum score which you can get is 9. So when you have a patient, you really put the patient in this matrix, which is there on the right side of the page, and come with a scoring system. And if a score comes to a value, which I will discuss with you before, a cutoff value, then you really have to anticoagulate this patient unless the risk of bleeding outweighs the risk of benefit regarding the patient. So who should get stroke prevention atrial fibrillation? This mnemonic we are using for the patients to say stroke prevention atrial fibrillation. And the guidelines are nearly unanimous So the American College 2019 guidelines versus European Society guidelines, they say very clearly that all patients should receive anticoagulation except those who have the lowest risk of this table. And in these patients, it can be reasonable to omit anticoagulation therapy. Who are these patients? These are the patients which are male with a score of 0. That means even if you have a single risk factor in male, you really have to anticoagulate. And the female, because the female sex itself is a one risk factor. So if you have only one risk factor, which is because of sex, then you can also omit anticoagulation. The level of recommendation vary between the European Society and the American Society. The European Society give it as a 1A recommendation, and the American give it as a 2A recommendation. But one thing is clear, that if you have any scoring beyond this, then all the guidelines, they unanimously agree that you need to have anticoagulation. So this point has been clarified over the years that which patient should have anticoagulation. But the big change in the treatment for the stroke prevention in atrial fibrillation came after the invention or after discovery of novel anticoagulation. And like in the computer versions, software versions, we have version 1 and we have version 2. So the development of oral anticoagulation was actually 2.0 phase of treatment of stroke prevention atrial fibrillation, because it made the treatment of atrial fibrillation much more agreeable, much more easy, much more compliant to the patient. Because we know warfarin is a good drug, but warfarin has got many side effects, particularly related to the toxicity of the neurotherapeutic index and the interactions. So the patient should avoid certain amount of food. And all of us will remember the days, a decade back, in which every day there are 2-3 patients waiting in the clinic to be anticoagulated dose to be adjusted for the warfarin. And once you adjust the dose, you have to keep checking the INR. And one of the common things which was seen in the emergency room are the patients who are in warfarin, who are going to undergo surgery, we need to stop, or more sinisterly, some patients who are in warfarin and present to the ER with a bleeding complication. So the introduction of NOAC meaningfully changed the scene of stroke prevention atrial fibrillation, and we can actually glean the data from the meta-analysis. So we don't have any stroke prevention comparison trials, but the meta-analysis of nearly 71,000 patients, which were included in the pivotal clinical trials of stroke prevention trials. So these are the 4 drugs, and you can see when they put all these drugs together, we can see that the nearly 19% reduction in the stroke and systemic embolism, with a nearly an absolute 10% reduction in mortality and a 14% reduction in a major bleeding, which occurred by the introduction of NOAC over warfarin. So both the arms were having some form of anticoagulation, but the arm which received NOAC did better, much better than the arm which received vitamin K antagonist, which is warfarin. So this randomized trial was also seen in the real world data, and this real data, and one of the largest study was including nearly 52,000 patients, was Garfield study. And I'm sure Dr. Omers, both Dr. Omers will remember that we participated, all of us participated in the Garfield study. And from Fujira, we contributed nearly 52 patients, and the Garfield study showed more higher advantage of NOACs over warfarin with respect to the mortality. So the survival advantage over 2 years was the tune of 19%. And all of us will agree, this makes as a compelling evidence to use NOAC over vitamin K antagonist. So we have 4 NOACs available in clinical practice in UAE. We have dabigatran, rivaroxaban, apixaban, and the latest anti-edoxaban. And among them, 3 are actually factor 10 antagonist, and dabigatran is the only one which is antithrombin. And so it acts at more distal level in the coagulation pathway than anti-10A factors, which are acting little more proximally. There are some important differences. For example, dabigatran is a prodrug. Half-life is nearly the same, between 5 to 10 hours, although the half-life of rivaroxaban is on the shorter side. And the dosing, important point about dosing is that all drugs are taken BID. So 2 drugs are taken BID, dabigatran and apixaban, and 2 other molecules, rivaroxaban and edoxaban, are recommended in the OD doses. And the renal excretion among them is highest with the dabigatran, and among them, rivaroxaban, apixaban, edoxans are nearly 35 to 50%. So there's a very important, they have to actually modify the doses of these drugs in the presence of renal impairment. So the question comes when we choose our patients, like for the hypertension, are all NOAC same? So are the dabigatran, rivaroxaban, and apixabans are equal in the clinical practice, or there are a subset of population in which we tend to use one NOAC over another. And this is the focus of our talk in our sessions today. So these drugs have not been tested against each other. So there are no trials which compare head-to-head dabigatran versus rivaroxaban versus epexiban, unfortunately. But all these trials have been pitted against each other. So all these epexiban, rivaroxaban, dabigatran, edoxaban in the pivotal clinical trials have been fighting in the ring against warfarin. And all these trials have shown they are either equal to warfarin or they're superior to warfarin in many components. But few of them showed a very clear outperformance with respect to warfarin. So we can take across the clinical trials and come to some agreement from the pivotal clinical trials to glean some data. So when you take the clinical data for dabigatran, rivaroxaban, and epexiban, which are available at the EHS services, and they are the popular, dabigatran are 2 doses in the clinical practice. Both are recommended for atrial fibrillation. The lower dose of dabigatran, 110 milligram BID, and the higher dose of dabigatran, 150 milligram BID. Rivaroxaban used in 20 milligram OD, and epexiban used in 5 milligram or 2.5 milligram BD. One thing is coming out very, very clear that they are very, very powerful in reducing hemorrhagic stroke. So you can see from this table that highly significant reduction in the presence of hemorrhagic stroke, which is one of the most needed complication of vitamin antagonists. Alhamdulillah, all the NOACs are extremely effective in reducing hemorrhagic stroke. But what about reduction of stroke and systemic embolism? Only 2 NOACs were found superior to warfarin for reducing stroke and systemic embolism. One includes the higher dose of dabigatran, not the lower dose of dabigatran. And the second trial was epexiban in the Aristotle trial. So only 2 molecules were shown superior to warfarin for reducing stroke and systemic embolism. So I will try to put all the benefits regarding all the NOACs in the simple table. So it appears very, very clearly that the safety point of view, the major bleedings, because we have a bleeding inside the brain, and we can have a bleeding from the GIT or other areas of the body. The major bleeding were also reduced only by 2 molecules. So the rivaroxaban had no reduction in the major bleeds. The higher dose of dabigatran had no reduction of major bleeds, but the lower dose of dabigatran was 110 milligram BID, which was equal to warfarin for the stroke prevention, had a lower bleeding as compared to warfarin. But however, epexiban, which showed a reduction in the stroke and systemic embolism, also had a major reduction of bleed by nearly 31%. So the net clinical benefits, which we are interested in the mortality and the net clinical benefits, was shown only by two molecules. First was the higher dose of dabigatran, and second was epexiban. So if you will put all this thing which I told you in the last 2 slides in the single slide, it appears much, much more clearly that epexiban, whether it is 2.5 milligram or 5 milligram, where the dose of epexiban is calculated by number of variables, it is having a better outcome with respect to the stroke and systemic embolism. With respect to integral hemorrhage, obviously integral hemorrhage is shown effect from almost all the molecules with respect to mortality and with respect to major bleed. And the same was seen with the lower dose of dabigatran, which had better integral hemorrhage, reduction in the major bleed, but equal to the stroke and systemic embolism. Higher dose of dabigatran had an improvement in the stroke and systemic embolism, improvement in ICH, but no reduction in the death and no effect in the major bleed in this general population. Another group of patients we see in the clinical practice are those patients in which we cannot give anticoagulation. And we are afraid to give anticoagulation. And in the old times, before the European guidelines and the American guidelines become much more clearer, the one alternative to be considered was using aspirin in the population, because we have seen from the initial trials of warfarin that aspirin provides some amount of protection for atrial fibrillation, but not to the quantum which warfarin provides. So one trial was done, which is called Everest trial, which pitted epexiban against aspirin in all those patients which were found as not to be fit to give an anticoagulation by vitamin K antagonist. So they couldn't be randomized. And in this trial, what was seen was that these are the patients which were unsuitable for vitamin K antagonist, number one. And this, in the real life, up to 25 to 50% of populations are there. And these are the patients who are randomized to normal dose of epexiban and aspirin. And the outcome was even more strange, and surprisingly, the primary endpoint, which is the reduction in the stroke and systemic embolism, was reduced by nearly 55%. So you can see the green bar is the bar with the epexiban, and the red is with a placebo or with aspirin, and there was a reduction by nearly 55%, and the major bleeding was the same. So it appears that epexiban is having the same safety profile as that of the aspirin with regard to the bleeding, obviously much more higher efficacy with respect to stroke and the systemic embolism protection. One population we see in our clinical practice are those people with a previous stroke and the TIA. And in the pivotal clinical trials of NOACs, which is Aristotle, Relay, Rocket AF, and so on, nearly 20 to 30% of our populations were having previous what you call as a stroke or previous stroke at a TIA. And the question comes, which drug do we choose, or are all the drugs same? So what you can see, this is the forest curve graph of all the patients which received with the previous CVA or the TIA in the pivotal clinical trials. And you can see with respect to stroke, it is actually Aristotle trial which showed far more better curves. So the curves were shifted to the left side, indicating far more efficacy, whereas the Rocket AF trial and the Engage trial were kind of neutral in the general population. However, intracranial bleed was shown to be very, very effective across all NOAC, and this was seen as a general. So when it comes to intracranial bleeding, absolutely all NOACs are nearly same. But when it comes to the efficacy regarding stroke and systemic embolism, the outcomes are a little bit different. Whatever drug you choose, it is very, very important that you have to start NOAC soon after TIA and the CVA. And for this, we follow the rule of 1, 3, 6, and 12. The time doesn't permit for me to go into this algorithm. But if you give this patient NOAC soon after the TIA or presentation of the TIA or the CVA, you can have a 22% improvement in the survival in the general population. Unfortunately, the population in the UAE is getting older, and we in the government hospitals, including Dr. Omar, myself, and many of the people in the room, are dealing with a population which are getting overall much more elderly. So this is the patient of atrial fibrillation we commonly see. Depending which side of the elephant you're standing, if you're standing in the front or you're standing on the side, you see a different projection of the elephant and what area you want to focus and what area you want to protect. It is possible that our patient with atrial fibrillation is an elderly patient. It is possible that our patient with atrial fibrillation is having a GI bleed or at high risk of bleed because of dyspepsia or the previous bleeding, or he's got some amount of ulcers in the stomach. It is possible that our patient is a young patient or a middle-aged patient and his kidneys are not very strong. So there is some amount of CKD and the renal impairment. And we have a subset of patients with a CKD which can compromise up to 1/3 of patients with atrial fibrillation. And this particular last part, I leave for Dr. Omar to talk about somewhere down the line, which he will speak after me. So the question comes to us in this room, how safe are the NOAC in the elderly patient with atrial fibrillation? So you can see in the pivotal clinical trial of Aristotle, the overall in the elderly population, the incidence of stroke increases far more rapidly. That is why as you become older, the CHAT scores increase more rapidly in order to have a more aggressive approach to prevent stroke and the atrial fibrillation. But in this population of the Aristotle, nearly 2/3 of the population were young and the 1/3 of the population were the older. And what we could see that in the elderly population, the benefit which we derive for the stroke and systemic embolism was irrespective of the age of the patient. All this population derived equal benefit in the stroke and systemic embolism, and a younger population derived less benefit, and the older population derived more benefit. But with respect to the hazard of the major bleeding, all the population did equally well. So this advantage of the elderly population for the stroke and systemic embolism was not seen uniformly with the other anticoagulation. For example, you can see this apexaban, age more than 75 and age less than 75. The hazard ratio of major bleeding was reduced across all the subset of population, but for dabigatran and the rivaroxaban, the results were not very clear. So the elderly population of rivaroxaban, the bleeding risk was neutral. It was as much as warfarin. Although you can see the curve has reached on the right side of the unity, and the same thing for the higher dose of dabigatran, the bleeding risk was higher than that of the warfarin. So it appears as the population is more elderly, it may be perhaps more wiser to choose apexaban because the bleeding risk is very important. And once the patient have a bleeding, then you really cannot resume NOAC for quite amount of time. And this is the general consensus. So in a paper, an interesting paper which came on 2017, before that, we will just see how does NOAC they compare to each other. So the most common site of bleeding with the NOAC is occurring in the GI bleeding. We will focus a little bit on the GI bleeding a little bit down the line. So in one big meta-analysis, which include nearly 56,000 of patients, which compare different dabigatran, and this is from observation study. It is not for the randomized trial. it was shown that dabigatran and the rivaroxaban are actually equal in the bleeding. So there is no difference in the bleeding versus dabigatran and rivaroxaban. But when you compare apixaban to another set of molecules, you can see the risk of bleeding comes down dramatically. So it appears that among the molecules, it is dabigatran and the rivaroxaban with the higher bleeding as compared to apixaban. That is why the European paper, which came out in 2017, which looked at choosing the NOAC in the subset of patients, it talked about that expert recommendation by a Diner in European Heart in 2017. And the group said very, very clearly, for the elderly population, more than 75 years of age, the first drug of choice should be apixaban, 5 milligram BID. And the second choice of the drugs should be all other anticoagulation. And if we choose dabigatran, we have to choose the lower dose of dabigatran, not the high dose of dabigatran. And the rivaroxaban, there is only standard dose, but there is no trial using lower dose of dabigatran in the elderly population. Similarly, the recommendation which came out in 2020 by the international consensus validation by a FOTA levels. So this FOTA level is something which is called as the fit for the age classification, in which they classify the drugs as A, B, C, D for the aged population. And among them, the anticoagulation, they give A, which is indispensable for apixaban, and for rivaroxaban, dabigatran, and warfarin, the level of recommendation is not A, it is B, means that is beneficial. So certainly, whatever NOAC you choose, it is beneficial, but apixaban is the one which is recommended by the FOTA group as indispensable. So we know that the bleeding occurs in the patient with the NOAC, and one of the most devastating bleeding occurs in the intracranial hemorrhages, which the NOAC do a wonderful job in reducing. But the question comes, does NOAC increase the risk of GI bleeding in patient with atrial fibrillation? Now, GI bleeding in the patient with the NOAC or warfarin is a special category, and it is, we know that elderly populations are prone to the risk of bleeding from the GIT. For example, if you take warfarin, there is a high risk of major GI bleed in patient with a previous history of GI bleed, 30% at 3 years versus 5% with no history of GI bleeding. Similarly, in dabigatran, in the RELY trial, it was shown there was an increase in GI bleeding in patient greater or equal to more than 75 years. And the same thing was seen in rivaroxaban. And the risk of dabigatran rivaroxaban was associated by nearly 1.5 time to twofold increase in the risk of GI bleeding, irrespective of warfarin. So much that the guidelines talked about not at all using NOACs in the population. So they said in the 2021, and one of the articles which came in the Journal of Clinical Pharmacy, they said in the population with prosthetic valve, antiphospholipid syndrome, and the high risk of bleeding, it is a good idea to use warfarin over NOAC. I don't agree for them. We can select the NOAC little more in a wiser way to find out which NOAC patients they will do better with what NOAC. So why the people with the have a high risk of bleeding from the GIT? There's a very, very strong interaction between the NOAC and the GIT system. In the GIT system, the bleeding can occur because of the systemic anticoagulation effect. Obviously, the anticoagulation make the blood thin and there's a propensity to bleed, but there is a local action of NOAC and the warfarin on the intestine. This is related to the incomplete absorption. So some amount of anticoagulation stay in the stomach. Dabigatran is a titrate molecule, little more cause acidity. So there's a direct caustic effect of the moiety of dabigatran by itself. And more importantly, like aspirin, there is an inhibition of mucosal healing. So whatever NOAC you choose, or you choose vitamin K, there is unfortunately higher risk of bleeding, which can occur in the patient from the GIT system, and the elderly are more prone to that. So in the pivotal clinical trials of NOAC, whether it is dabigatran, rivaroxaban, and apixaban, the lowest amount of bleeding was demonstrated in the apixaban, and this is the number of percentage per year. You can see with the apixaban is 0.76, and for dabigatran is 1.85. Obviously, we cannot compare these numbers because different set of populations were included in the different clinical trials, and they are not really comparable. But what do the guidelines say? So in the European 2016 guidelines, they say in a special category for the patient at the high risk of bleeding, they say in the patient at high risk of bleeding, vitamin K antagonist or another NOAC preparation should be preferred over dabigatran, rivaroxaban, and edoxaban. So they did not say by name, but obviously they implied that apixaban is superior to them. By 2020, the guidelines are very, very clear. They said that in the patient with atrial fibrillation and the GI disorder, consideration should be made for the drugs as apixaban which are not associated with an excess of GI bleed as compared to warfarin. So it appears that among the NOAC, if you have a patient who has got a GI bleed or prone to GI bleed or some ulcer or dyspepsia, it may be perhaps a good idea to choose apixaban over other anticoagulation. The same data came out for the network analysis, and this network analysis is a huge network analysis, 25 randomized trial, including nearly 140,000 patients, and it was showed very, very clearly in this meta-analysis that it is the apixaban and edoxaban had the most favorable major GI bleeding safety profile, whereas rivaroxaban and dabigatran were actually the least safe for him. Another set of patients we commonly encounter in the clinical practice are those with the renal impairment. Now, this is a special tricky population because we know very, very clearly that 1/3 of atrial fibrillation patients have some form of CKD. So the GFR is not very robust. They have a varying degree of CKD. Some people have a modest decrease in the GFR, and some people are at the end-stage hemodialysis, which are having atrial fibrillation. In the old times, the patients with the end-stage renal hemodialysis, we were actually recommending vitamin agonist, and these people were miserable people, were suffering all the time, and we get a call from dialysis unit, doctor, what about INR, what about the PTT for this patient? Unfortunately, presence of CKD, just by the presence of CKD in the atrial fibrillation makes the outcome worse with regard not only to stroke and systemic embolism, which goes up by nearly 2 times. So you can see that the stroke and systemic embolism goes up by 2 times. And unfortunately, the risk of bleeding also increases, partially related to the factors which are specific to the patient with CKD, such as the platelet dysfunction. So these are the population which much more high risk of the bleeding. One more thing which is important in the patient with a CKD, the some amount of dose adjustment is required for dabigatran, rivaroxaban, edoxaban, only because of the renal functions. For example, over the GFR or the creatinine clearance dose below 50, dabigatran have to be decreased the dose. Once it is below 30, for sure, you have to reduce the dose. Rivaroxaban cutoff is from less than 15 milligram, and if it's less than 15 ml per minute, you have to stop rivaroxaban. It is kind of contraindicated. Apixaban, we have a dose which is dependent upon the 3 factors. It is just not at all dependent upon the kidney function. It is dependent upon the age of the patient, is depending on the body weight, and is also dependent on the kidney function. So a deteriorated kidney function does not specify reduction in the dose of apixaban only on the basis of kidney function. Although no doubt, patient with the altered kidney function, they are small body size and they can be elderly also. But apixaban, if you have only renal function which is affected, you can actually continue high dose of apixaban up to the GFR of 15 ml. And the latest update is that you can even give apixaban in the patients with the absolute no renal function who are actually having hemodialysis. And that is one of the reasons by all the guidelines they recommend assessment of kidney function in atrial fibrillation. So guidelines say very, very clearly that anybody who is having atrial fibrillation and you want to start NOAC, assessment of kidney function by creatinine or the creatinine clearance is recommended in all atrial fibrillation patients to detect kidney disease and to correct supporting dose for the atrial fibrillation therapy. And once you do it, it is recommended to do yearly kidney function. We tend to do a little more frequently. So at least minimum once in a year, you have to do renal functions. What about the outcome data for apixaban? So 270 patients were there which were having a GFR between 25 and 30 in the Aristotle trial. So these were the 230, 100 patients. And what was seen that in this population, the risk of major bleeding and the risk of the major non-renal bleeding was reduced by nearly 65% as compared to warfarin. So as compared to warfarin, the trend in the kidney failure patients were like in the normal patient, a substantial reduction in the major bleeding. And it did not matter whether you use 2.5 milligram of apixaban or 5 milligram of apixaban, you actually tend to derive equal benefit in the population with regard to respect to the major bleeding reduction. So in the network analysis, which looked at the risk of major bleeding regarding the kidney functions for all the molecules, apixaban, dabigatran, and the rivaroxaban, was seen very clearly that when the GFR drops below 50, the stroke and systemic embolism was reduced by nearly all the drugs, but the major bleeding was mainly affected by apixaban as compared to dabigatran or rivaroxaban, where you can see the risk of the bleeding is just in the unity, but this is actually, and apixaban where when the GFR drops below 50, the risk of bleeding goes on the left side, indicating superiority over warfarin in the general population. So it appears when the patient is high risk of bleeding, more fragile, probably apixaban is better than other NOAC in the general population. So in the paper of European Society, which looked at the statistical analysis as compared to the general population, they said that the NOACs have similar efficacy and safety as compared to warfarin across different renal function. And indirect comparisons suggest that apixaban and edoxaban were associated with a better safety profile in the patient with a moderate renal function. So what are the guidelines that talk? The guidelines that talk about which NOAC about warfarin in the renal impairment, and this is a paper for the European Heart Journal practical guidelines for use. And they said very clearly, Stephen, who comes and speaks sometime in Dubai also, that the rate of major bleeding with apixaban was reduced more because we can only talk about the trials versus warfarin in patients with the impaired renal function. In view of the individual NOAC pharmacokinetics, 27% renal clearance of apixaban, and available it is for randomized clinical trial. The use of apixaban and edoxaban may be preferred over dabigatran and rivaroxaban in the patient with the kidney function impairment for him. So summary, what is the summary? That the renal impairment is associated with a graded increased risk of ischemic stroke and systemic embolism. So each one goes up by nearly 2 times. As compared to warfarin, NOAC offers a clinically meaningful and greater incremental benefit and safety, mainly related to the stroke and systemic embolism, but the bleeding risk came down only by the apixaban. Apixaban has shown better outcomes versus warfarin in patients with atrial fibrillation and the renal impairment with respect to stroke event and the major bleeding. With this, my friends, I am actually coming to the end of the talk by saying that atrial fibrillation is the most common arrhythmia seen in the clinical practice. It is dangerous outcome. More than the symptom burden is the risk of the stroke, which makes the atrial fibrillation and sinister arrhythmias in the clinical practice. Most of the patients need to be anticoagulated. Yes, we have sometimes vaguely limited atrial fibrillation, young healthy people who need not be anticoagulated. If you choose the anticoagulation, use of NOAC offer better and measurable benefit over warfarin. So the NOACs are preferred over vitamin K antagonist. Now we all have individual preferences when we want to choose NOAC. We can choose apixaban, dabigatran, rivaroxaban, edoxaban, but the literature and the science is suggesting very clearly that it is actually apixaban which offer advantages over many clinical scenarios such as elderly, those with the risk of GI bleeding, and the renal impairment. And with this, thank you for your kind attention. And I give the floor to Dr. Omar back.
Thank you very much, Amrish, for this presentation. It was a very nice summary of like an overall of all the randomized control trial, of the index trials, and the real world data comparing the NOACs. I really appreciate the talk, and now I have a clearer vision on which NOAC to choose in which subset of population. Thank you very much for the presentation. So we're moving now with Dr. Amal Haj. He's going to give us a deep dive when it comes to NOAC in patients with coronary artery disease, which is a very common scenario that we're facing more and more nowadays. That you have a patient coming with acute coronary syndrome, and you have a presenting symptom or a presenting coexisting factor as an atrial fibrillation. So he's going to take us through this. I just need to mention maybe that the question and the discussion will be left later on. And please send us all the questions. And if you want to address a specific physician, please mention that in your text. Thank you very much.
Hi, good evening, everybody. Can you hear me?
Yes, we can hear you, Amar.
Okay, great. Good evening, everybody, and thank you for joining this Zoom meeting today about NOACs in different clinical settings. And thank you, Amrish, for such a great presentation. I congratulate you in squeezing all this data in just half an hour. It's been very educating. Thank you very much. Now I will take on from here and talk about the common problem of atrial fibrillation with acute coronary syndromes. The interrelationship between atrial fibrillation and coronary artery disease is very well known. In clinical practice, you very often come across a patient with atrial fibrillation who develops angina or has an acute coronary event, and vice versa. You have people who come in with acute coronary events and you discover that they are on treatment for atrial fibrillation. The interrelationship between the two has a lot of implications, and one of the implications which we're going to concentrate on today is the post-procedural or post-development of an acute coronary syndrome management, because as you know, the two conditions are treated differently because of the pathophysiology of both of them. Now, the main problem with atrial fibrillation obviously is thromboembolism, and for long we knew that the best way to treat or to prevent thromboembolism in these patients is by treating them with anticoagulants. And warfarin has been the mainstay in that respect for years, until the recent, obviously, development of the new oral anticoagulants. On the other hand, coronary thrombosis is mainly mediated through thrombocytes or through platelets, and the treatment is always been antiplatelet agents, starting years back with aspirin, and then diclopidine, which is no longer in use, I don't think. And then we had Plavix or clopidogrel, and more recently we had two new classes added to the armamentarium of that. So when you have a patient that is suffering with atrial fibrillation and develops an acute coronary event, there is always, or there has been, a lot of problems with regards to what sort of regime that you would use for the treatment of these patients. Obviously, the two challenges that face everybody, or the two areas that everybody has to think about, is number one, is my treatment going to prevent this patient from developing a stent thrombosis or reocclusion of this artery, or reoccurrence of the acute coronary event? And on the other hand, is this treatment also going to prevent the patient from developing the horrible complications of thromboembolism related to the atrial fibrillation? And obviously, to strike this balance, you have to think very carefully about bleeding events, because when you combine anticoagulation with potent antiplatelets, you certainly increase the likelihood of bleeding. And there have been several studies when people started to think about these regimens, trying to identify, first of all, what is the best regime, and the second, most importantly, how long are we going to use that regime? And throughout the last 10 or 12 years, people have obviously fine-tuned the combination of antiplatelets and anticoagulants, and we'll talk about how did that happen, and we'll also have a reference to the current guidelines regarding the management of these. Now, the first exciting study that came out, I think, in 2013, is the WOEST study, which was conducted in the Netherlands and Belgium, and it was really quite a well-respected study, and it was very highly referenced, despite the fact that there's only a small number of patients, 573 patients. And at that time, the majority of them, or probably all of them, were taking warfarin for anticoagulation for different reasons. Then more than 90% of the patients actually had atrial fibrillation. About 5 or 6% of them had prosthetic heart valves. And these patients developed acute coronary events, and they required stenting with either drug-eluting or bare metal stents. And then they asked a very simple question in this study. They randomized patients either to receive aspirin along with the anticoagulant, or to have dual therapy with aspirin and another antiplatelet, which is obviously a Plavix. And they looked at the outcomes up to 1 year. The treatment was for 6 months, but they looked at the results after 1 year, and there was clear difference in terms of the primary endpoint, which is mainly a safety issue, and it's bleeding. And clearly, when you use triple therapy, there is a very high number of bleeds related to the three drugs compared to dual therapy with just an anticoagulant and Plavix. And the unfortunate thing is that the study was not really powered to look into the long-term sort of stent thrombosis and thromboembolic events, but clearly there was absolutely no difference in terms of the events relating to stent thrombosis and thromboembolic events. And the message from this study was that triple therapy causes more bleeds, and it does not really affect the stent thrombosis and thromboembolic events. And people obviously started to think about really modifying their strategies in treatment of these patients from that day. Another study, which is the ISAR triple, it was preceded by another ISAR study, which is the ISAR safe, and that one just looked at the safety of using the combination of aspirin, Plavix, and an anticoagulant, and it was clearly again that there was an increase in bleeding. Here from this study, clearly you can see that again the numbers are not huge, but it's a good number, and patients are also again randomized for having either aspirin and Plavix for 6 weeks or 6 months, and they looked at the net effect on these patients after 1 year. The difference was very minimal at the end of 9 months. Again, this shed light on the duration of the anticoagulation and the duration of the antiplatelets. And the message we get from this study is that probably people don't have to give these drugs for a long period of time. There's always been thinking that the stent probably needs between maybe 6 to 12 weeks to endothelialize and become resistant to stent thrombosis. But I think from this studies, it's clearly that it's not the case, and you can safely give these drugs for only 6 weeks without really. You can see here there is no difference in the composite of myocardial infarction, stent thrombosis, stroke, or major bleeding. Now with this again, this study, the majority of the patients were actually taking warfarin. And this study was published, I think, again in 2011 or 2012. Now, after that, obviously, with the NOACs, they have to have their own data. And 4 major trials from all the 4 available NOACs were carried out. The Pioneer AF PCI, which looked at the rivaroxaban, redual PCI, which is dabigatran, and Augustus ACS, and lately edoxaban study, which is the Entrust AF PCI. And these all studies, they've had different sort of protocols, and the methodology was different. But they all looked at the two questions. First of all, the safety of giving these medications compared to warfarin, and the second thing is obviously the duration of the treatment, as how long you can safely give this treatment without affecting the outcomes. If you look at the size of the studies, obviously the biggest study is Augustus, which is a apixaban study, and we'll talk about it in great detail later on, because it's one of the studies that actually has led to a great modification in the international guidelines. And they're all sort of like multi-center, randomized, open label studies, but as I said, there are slight differences in the methodology of the studies, and the population is non-valvular atrial fibrillation with an acute coronary syndrome and a PCI and a stent. The only study which included people who were treated medically for an acute coronary syndrome is Augustus again, and it also has helped in the drawing the guidelines regarding anticoagulation and antiplatelet therapy in this type of patients who actually do not receive a stent, but they have a documented an acute coronary event. If we start with the pioneer AFPCI, which is they used rivaroxaban 15 milligrams and Plavix 75 milligrams or clopidogrel 75 milligrams. It's interesting that they chose the 15 milligrams rather than the 20 milligrams. So there was no clear indication why they chose that. It's very strange, because for atrial fibrillation, you normally use 20 milligrams. What they did is they gave this for 1, 6, or 12 months pre-randomization. According to the PCI center choice. And then they also used rivaroxaban 2.5 milligrams along with aspirin and Plavix, and they used vitamin K with both aspirin and Plavix, and they titrated the INR between 2 and 3. The dose of aspirin was between 75 and 100 milligrams once a day. And obviously, there was clearly a reduced risk of bleeding with a low-dose rivaroxaban-based regimens. But again, as I said, this is not the usual doses that we use for the prevention of atrial fibrillation. The triple therapy, wherever you use aspirin, you always end up with more bleeding, as we can see from all these studies. And I think that is one of the powerful messages that came out from these studies. With regards to thromboembolic events and stroke, myocardial infarction, and cardiovascular death, there is absolutely no much difference between the three regimens that have been used. Redual PCI, again, it's a strange study because they use 2 doses of dabigatran, 150 and 110 milligrams, along with a Plavix, or compared it to warfarin plus PY2 inhibitor plus aspirin. So you're talking here about a dual therapy here compared to triple therapy with the warfarin, again, as expected with warfarin triple therapy, there's excessive bleeding compared to the dabigatran 110. But when you look at the 150 milligrams, the difference is less. Still significant, but it's less. So the message again here is if you're using warfarin, triple therapy is probably quite dangerous for these patients. Now the edoxaban study, again, they used the full dose at 60 milligrams along with Plavix, and they compared it to triple therapy with warfarin, Plavix, and aspirin. And as expected, the more obviously bleeding with the vitamin K antagonist triple therapy. So if you look back at the guidelines back in 2018, the major concern obviously is either the patient is high risk for thrombotic events or the patient is a high risk of bleeding. And this actually is still the case when you have a patient who had a PCI and who is also an AF patient. There is no fixed regimen that is there for everybody. Every patient has to be assessed on his own merits. If you feel that the patient has a very high thrombotic risk, and there are lots of pointers towards that, if the anatomy of the coronary arteries, or if you used multiple stents, or if there are any features to suggest that this patient is a high risk of stent thrombosis, then obviously you have to prolong the duration of the triple therapy. In the past, they can go up to 6 months. But I will show you the most recent guidelines, which again looked at this, and they don't feel that that is warranted. People who have obviously high bleeding risk, you can only use triple therapy for a month or maybe even less, and then continue for the rest of the year with dual therapy. After 1 year, it has been, and it's still the case, you do not use anything other than this oral anticoagulant in a patient with coronary artery disease and AF. After 1 year, you have to stop that. And we will talk about that later on, because there are some people who are still using antiplatelets along with an anticoagulant beyond the 1 year because of some small trials which have shown that there is actually benefit regarding late or delayed stent thrombosis. The American guidelines, again, they look into the same sort of scenarios. If the patient is prothrombotic, then you have to prolong the duration of the triple therapy. And if the patient is high risk of bleeding, then you try and shorten that as much as you can. Now, if we just go back to the trials, and we talk about the Augustus trial, which is it's a landmark trial in terms of the treatment of acute coronary syndrome. And the trial obviously used the 2x2 factorial design. And what they did is they used apixaban 5 milligrams once a day. And obviously, when it's indicated, they use the reduced dose of 2.5 milligrams, twice daily in these patients. The patients were randomized to either the apixaban or vitamin K antagonist, and they double-blinded them. Some of them, they actually received aspirin, and some of them received the placebo. And with the vitamin K antagonist, is the same, is double-blinded either to aspirin or placebo. The patients all have a background of a PY2 inhibitor, PY12 inhibitor. Mainly, more than 90% of the patient received Plavix. So there is triple therapy with aspirin. There is dual therapy with a placebo in either arm. CHA2DS2-VASc score is, the mean is about, sorry, I can't see this because of the pictures. I think it's about 3, and yeah, it's actually the CHA2DS2-VASc score is much higher. It's nearly 4. And the HAS-BLED score is moderate, it's close to 3. Plavix is over 90%, as I mentioned. Ticagrelor and Prasirgil are really very low numbers. And again, these two drugs, if I can just mention now before I forget, is they're not really recommended in patients with atrial fibrillation and acute coronary syndromes. So we should probably try and avoid them as much as we can. There are some people who still like to use them in a patient with a STEMI, but obviously they have to assess their bleeding risk and make sure that they are not very high bleeding risk patients. Okay. So the questions, obviously, as you can see from the study design, is an apixaban-based triple therapy non-inferior or superior to a warfarin triple therapy in terms of reducing bleeding? Does an apixaban also result in fewer deaths and hospitalization compared to aspirin? Does this regimen with apixaban causes fewer ischemic events? And what are the benefits, risks of aspirin in this population? And I mean, I think, as you can expect, this is the curves regarding the relative risk of bleeding, and clearly with apixaban, there is significant, I mean, it's clear improvement in the incidence of bleeding. It caused less bleeding events compared to warfarin. Aspirin compared to placebo, no surprises there. I mean, it's obviously significantly higher in terms of bleeding. And if you take all the four groups together, then I think the best profile is using apixaban plus Plavix is the best one, which in terms of lowest incidence of primary bleeding endpoint. At the bottom here, you can see this is apixaban plus placebo plus Plavix, followed by apixaban followed by the warfarin and Plavix, and then obviously followed by apixaban and aspirin. And the worst obviously is using triple therapy with warfarin. The apixaban-based regimen also resulted in 17% reduction in the relative risk of death, hospitalization, compared to warfarin-based therapy. And as you can see, all the apixaban-based combinations are much better than the warfarin. So the end result obviously is very clear in terms of clinically relevant major bleeding, and major bleeding as such for an acute coronary syndrome with PCI. Obviously, the treatment with apixaban it's led to quite a significant reduction in events and bleeding, and compared to warfarin, all the sort of the parameters are much better with an apixaban-based, whether it was death, hospitalization, major bleeding, and the same is true for all the scenarios of admission, whether it's an elective PCI, acute coronary syndrome with a PCI or without the PCI. It's always apixaban is better than warfarin. So the conclusions from that is that apixaban-based treatments are better than vitamin K based treatments in terms of major bleeding, cranial bleeding, intracranial bleeding. It's also better in terms of death and hospitalization. Also, there is a pointer of treatment as the dose approved for stroke prevention. That's obviously the 5 milligram, which is what we use normally in somebody with normal renal function, normal body weight, and younger than 80 years of age. And again, the message again from this study, similar to the other studies, is that aspirin is bad for you, increases the risk of bleeding. Now, just to touch lastly on the final guidelines which came at 2020, atrial fibrillation guidelines. This is for patients with acute coronary syndromes, and they obviously people who have ACS with a stent, people who have chronic coronary syndrome. These are obviously patients who come in for an elective PCI, and the patients who are medically treated for acute coronary event. Now, if I start with those ones, acute coronary treated events, the guidelines are very clear. There's no triple therapy in these patients. Don't give aspirin. You just use a NOAC and an antiplatelet, preferably Plavix, as I said, and you give that for 1 year. After 1 year, you give just the NOAC and you stop the Plavix. Now, if the patient came in with an ACS and had a stent, then obviously the first week, usually people end up with triple therapy. If you feel that the patient has a low bleeding risk and a high thrombotic risk, then you can give the aspirin as triple therapy up to 1 month, no longer than 1 month. I mean, always try and just limit it to 1 or 2 weeks maximum, the triple therapy, and then stop and continue with dual therapy for the rest of the year. For chronic angina patients, again, you obviously use a NOAC and a PY2. PY2 in this case can be for as long as 6 months, and then obviously long term you use a NOAC by itself. If the patient has a high thrombotic risk after a sort of an elective PCI, you find that the anatomy really is quite bad and the risk of thrombosis is high, then you can use aspirin alone, but similar to an acute coronary syndrome with a stent, but you try again to limit the duration of the triple therapy to less than 1 month, no longer than that. For ticagrelor and prasugrel, I think again you don't see there's any sort of recommendation for this. Actually, on the contrary, you have to try and avoid this as much as possible. The high thrombotic risk factors are obviously delineated here. It's a long list. Multi-vessel stenting, as I said. If the patient comes in with an acute coronary syndrome, obviously acute coronary syndrome happens in the context of an acute thrombotic state. Diabetic patients, patients with recurrent myocardial infarction, multi-vessel, concomitant peripheral arterial disease, and premature coronary artery disease. This is important in young people. Luckily, they don't actually have atrial fibrillation that much. I mean, as you heard earlier on, the atrial fibrillation is much commoner in older people. Bleeding risk, obviously, we have the has-bled score, and you can use the has-bled score to try and identify your patient's bleeding risk. And to try and reduce the bleeding risk, obviously, interventionalists, they know all these tricks, and using radial access, use of PPI patients with dyspeptic symptoms. As you heard earlier, there's increased risk of GI bleeding with some of the NOACs. try and avoid unfractionated heparin, and bridging is not good. Again, if the patient comes in with an anticoagulant, the worst thing you can do is to stop the anticoagulant and bridge them with heparin and try and do the PCI. That's no good in terms of bleeding, because all the studies have shown that doing PCI on anticoagulants is probably safer than stopping and then bridging. Some situations you might need to do that, but often try and avoid that. And the GP2B3A inhibitors, they should also be restricted in these patients only for bailout procedures. Okay, I think I will stop here and we'll see if anyone has any questions. I think it's past 9 o'clock. Thank you for listening, and we'll be happy to answer any questions or any queries.
Thank you very much, Umar, for this great presentation. It's really a very common thing that we see where you have a patient coming in with acute coronary syndrome and is either known to have paroxysmal atrial fibrillation or he develops atrial fibrillation during the presentation. So it's a very common clinical scenario, and you delineated the issue very, very nicely. Thank you very much for the presentation.
Yeah, so well, just one point, something maybe I haven't mentioned, that the occurrence of an acute coronary syndrome itself increases your risk of developing AF by nearly 60–70%. So it's not uncommon, and that makes it even more difficult to manage. I mean, I think the common thing is that people develop AF for maybe during the time of their acute coronary syndrome, and most of the time they sort of like revert spontaneously within 24 hours or so. These are the type of patients who are really not treated very well, because people think, oh, it's just because of an acute event, let us just forget it. But I think that's wrong. If the patient has such a scenario, you have to treat him as a patient who needs anticoagulation, because having had an acute coronary syndrome by itself, this is regarded as vascular disease and already puts your child's VASC score as 1 if it's a male and 2 if it's a female. And just to add that to something that's haven't mentioned in the talk.
That's very true. That's very true. So any questions from the audience?
Just I have a question for Amrish. Amrish, do you think we will ever see a trial comparing all these anticoagulants against each other?
No, I think we will not see them, because all manufacturers are afraid that something will come out which will put in the bad light. Number one. See, this question which Dr. Omar you addressed now in the talk, and is common problem in our practice, is that what about those patients who develop very transient atrial fibrillation with acute coronary syndrome, patient admitted with particularly circumflex artery? We know that some part of the artery supply occurs to the atria from circumflex, and this patient has a atrial fibrillation for maybe half an hour, 45 minutes. What is the cutoff for giving anticoagulation to such a patient? 5 minutes, 10 minutes, half an hour? How brief is the atrial fibrillation? You should consider benign and leave without anticoagulation, or even few beats of atrial fibrillation is enough?
Well, I don't think there is any clear guidance on this. I don't think there is any the usual cutoff most people use in these scenarios is 24 hours, of course. But I mean, we know from, for example, patients who have AF, patients with devices, that some of the studies have shown that even 6 minutes of atrial fibrillation is clinically significant and may warrant anticoagulation in these patients. So, I mean, if you think patients who have a pacemaker or an ICD has AF for 10 or 15 minutes, gets anticoagulated, why not this type of patients? I mean, as far as I know, that the observational studies have shown that these people are very, very high risk of subsequent AF and subsequent strokes as well. The same thing goes for post-bypass and post-valve surgery. These are also very often, you don't see them because they're in the surgical ICU. They give them amiodarone, they convert after 3 days, they send them home, and that's end of story. They don't even mention the AF anymore. They think, oh, it's 30% of people who have their chest open, they end up with AF. What about the other 70% then? So yes. I think these both groups of patients, they're known to have quite high subsequent morbidity related to atrial fibrillation, subsequent atrial fibrillation.
Yeah, I totally agree with. Yeah, please.
The one more question which you addressed actually before I asked you is that when you do a device integration and the machine does not, the patient is sinus rhythm at the time of integration, and the machine says that there were 4 AHRE events which were noted at the time of device integration. We can sometimes see an EGM, but the EGM strips are short strips, and the strip shows atrial fibrillation. So you actually said 6 minutes. Shall we take a 6 minutes or number of episodes which are more relevant in this? Like, for example, how do we analyze in our clinical practice which one to anticoagulate, which one not to anticoagulate?
Well, I think if you have AF more than 6 minutes and the patient has a high Chats-Vasquez score, I think it's safer to anticoagulate them. I will talk to them and I'll say, well, there's not as yet enough evidence, but if the patient has low bleeding risk, I think it's probably wiser to anticoagulate them. If he has a very high bleeding risk, then I will probably have a good discussion with them and let them weigh the risk-benefit ratio, and maybe we can do that together and come to an answer.
Yes. I will have a question for chairperson, please. Dr. Falasi, when you do a patient with ablation, and which patient you will actually take them off anticoagulant after ablation, or you will continue anticoagulation even after ablation? And what are the policies, the current recommendation from the practical point of view, who are not electrophysiologists, for anticoagulation after ablation?
Thank you very much for the question. So, as per today, there is not a single study that has addressed this question. So we actually don't stop anticoagulation based on a successful ablation. So you have a patient who has paroxysmal atrial fibrillation. He underwent a successful atrial fibrillation ablation. Even though he's not complaining of any palpitations, you should continue anticoagulation. So the cases where you should not anticoagulate or you can stop anticoagulation are the patients who have Chats-Vasquez of 0. Then you anticoagulate. My personal practice, normally in the guidelines says 2 months. I normally do 3 months, and then I stop anticoagulation for these patients. There's an ongoing trial, it's the OCEAN trial, where it's led, I think, by Medtronic or sponsored by Medtronic, where they're actually implanting a loop recorder in patients with atrial fibrillation that undergone PVI, pulmonary vein isolation. And they are following these patients. But I think even that trial, like the loop recorder lasts only for 3 to 4 years. So what happens after the 3 to 4 years if this patient actually developed atrial fibrillation again? And for me, to be honest, like from seeing more and more patients who underwent ablation, for some reason, patients who has undergone atrial fibrillation ablation, they are less symptomatic compared to what they were before the atrial fibrillation ablation. So I have plenty of patients where they will tell you, I feel fine, I don't have any recurrence of the arrhythmia. And when you stick in like a loop recorder or even just a Holter monitor, you can actually see atrial fibrillation recurrences in the tracer. So short answer, you don't stop anticoagulation based on a successful ablation.
Thank you.
So just to comment on what Umar was saying, I think we should become more and more aggressive anticoagulating patients who present with ACS and atrial fibrillation ablation, because as he mentioned, that the risk of them developing atrial fibrillation in the future is much, much higher compared to the normal population. And like I have seen it more and more that people have a tendency to go very lenient in dose, but I think we should become more aggressive in anticoagulating these patients. A lot of the risks that were associated with vitamin K are disappearing when you're talking about NOACs, as you demonstrated nicely in your presentation, Amrish. Like especially apixaban is a very safe drug. Like bleeding risk was comparable to aspirin, and we will easily give aspirin, but we're avoiding giving apixaban, even though the risk of bleeding is low and the benefit that's taken out of the medication is much high. So I think we should consider being more aggressive in these patients. Any other questions? Just
So Rania?
so Dr. Umar, there's a question Rania just text. Is there a place for ticagrelor as part of triple therapy post-BCI and ACS in patients with previous history of instant thrombosis while on clopidogrel? I'm sure risk of bleeding is higher with ticagrelor.
Yes, well, the answer is yes. I mean, I think some people who are using it, but the important thing is that, as I said, you have to assess the bleeding risk of that patient. And if there is absolutely no running away from it, and you find yourself that you have to use it, then first thing is you have to inform the patient and family that this treatment is likely to cause bleeding, but it's good for his stent. The second thing is you have to look around and see if there are any modifiable factors that you can actually use to try and lessen his risk of bleeding, as I mentioned, by using maybe a PPI, if there are any bleeding disorders, if the platelets are too low and stuff like that. I mean, you have to try and find ways of reducing this risk. But yeah, I know. I mean, I think there's still people using it, but it's a very high risk. It's a very high risk.
We have another question. Maybe Amrish can take this one on. It says, do you anticoagulate DVT patients with end-stage renal disease?
Yes. Now, the end-stage renal disease and the DVT are peculiar problems. We know that the extent prophylaxis for DVT is very, very helpful. So as of now, the drug of choice with end-stage renal disease in our population remains apixaban, unless they have antiphospholipid antibody or some protein C or protein C S deficiency. We typically anticoagulate with apixaban, 5 mg BID. But the only difference is that we don't give them the initial part of, we treat them initial part with low molecular heparin. And after 5 days, switch to apixaban, and they stay on apixaban. And many of this patient will stay on extended treatment, 2.5 mg BID.
Thank you.
So I think 2.5 mg BID apixaban for somebody who is a robust body weight and age is not very elderly, it's pretty safe dose for extended prophylaxis.
I agree with that, yeah. I don't see any more questions. So it's already 9:20. Maybe we'll conclude the meeting. Thank you very much, Umar. Thank you very much, Amrish, for your great talks today. Even myself, I did learn from you, both of you. Thank you very much for the presentations.
Okay, thank you.
Thank you.
Bye.